Okay, one last time. You know, when you gave me this lecture, you know, she's been giving people lecture topics. I didn't know what pubs was, so I had to look it up. I was embarrassed to tell you that. Okay. We always call it fetal blood sampling, so pubs? What's pubs? All right. So we're going to talk about 3 different things today: anesthesia for cephalic version, pubs, and TOLAC. All right, so here's the short version of the objectives, and we'll start with external cephalic version. So we're going to have a little audience participation again during this lecture. Who works in an institution that offers versions for breech presentations? So most people, okay? So the next question is, who works in an institution where you offer neuraxial analgesia for versions? Not quite so many people. Okay, so why do I ask that question? Well, there have been studies over the last decade asking the question whether or not neuraxial labor analgesia increases the success rate of external cephalic version. So I don't know if you've ever watched this procedure personally, but it's rather barbaric, okay? They press a lot and it hurts. And so the question is, if the mother was more relaxed and she had some analgesia on board, might the procedure have a higher success rate? So this is a meta-analysis that was published a couple of years ago of randomized controlled trials comparing neuraxial analgesia to no analgesia or to no neuraxial analgesia for attempted external cephalic version. There are a couple of these meta-analyses out there right now. I'm showing you this particular one because it was the first author is one of our former fellows. So this is a forest plot. You've seen them in the last couple of days, and each one of these lines is a study, and the red line right there is 1, the relative risk of 1. There's no difference in the success rate between the neuraxial group and the non-neuraxial group. And if you look at the overall result, which is that triangle at the bottom, you can see that it's to the right of the line, okay, which means that neuraxial analgesia improves the success rate compared to the control group, and the relative risk is 1.44. So you're 1.5 times more likely to have a successful version if the patient receives a neuraxial analgesic or anesthetic ahead of time. All right, so that's the first conclusion. Now, the studies are ordered in a certain way, and if you look at the top of this forest plot, you can see that the relative risk of all the studies at the top, those boxes, they all overlap 1, right? They're all overlapping the red line, okay? What is common to all of those studies is that the dose of neuraxial medications, and usually it's opioids and local anesthetics, was an analgesic dose. It is a dose that you would normally give for labor analgesia. So there's one study up there, the 4th one down, Sullivan, that came from our institution. We used for our study 2.5 milligrams of intrathecal bupivacaine with 15 mics of fentanyl and an epidural test dose. That's an analgesic dose. That's what we would normally give someone to initiate labor analgesia. And you can see that the total for the studies that gave analgesic dose, the risk ratio overlaps 1. There was no difference in those studies. In contrast, if you look at the studies on the bottom, all of those risk ratios are to the right of 1. In other words, the success rate for version was higher in those studies compared to the control group. And what's common to all of those studies is they received anesthetic doses of neuraxial analgesia. So what you would give someone to do a C-section, for example. So the block was much denser. In fact, the relative risk, if you looked at just those studies, was almost 2. All right? So this particular meta-analysis suggests, okay, number 1, that neuraxial analgesia is beneficial, and number 2, that more dense neuraxial analgesia is more beneficial than less dense neuraxial analgesia. But I will caution you that no one has head-up compared less dense to more dense neuraxial analgesia. So that study is underway at my institution right now. We are randomizing patients who present for external cephalic version to receive either 2.55, 7.5, or 10 milligrams of intrathecal bupivacaine along with fentanyl. And hopefully in a couple of years we will be able to tell you whether there's a dose response to this relationship. But I think that you should know that neuraxial analgesia improves the success rate. You can decide how you want to do it. It's out there in the obstetric literature. There's at least several editorials in the obstetric literature that suggest that obstetricians need to be asking us to provide neuraxial analgesia or anesthesia for these procedures. So if you're not doing it now, don't be surprised if someone asks you, or maybe you should volunteer to provide analgesia for this procedure. I mean, you can do it because there's a higher success rate, that's a good thing, but another reason to do it is it's more humane, I think, to do an external cephalic version with some analgesia on board. So Dr. Carvalho, who you heard earlier this morning, last year published a paper in which they did a cost analysis, all right, to see whether or not providing analgesia was cost effective. It obviously costs more money, okay? If it's not effective, then it's adding to healthcare costs. But if it is effective and you prevent a cesarean delivery, then we could argue that it's much more cost effective to do an neuraxial procedure and spend a little bit of money on that rather than a lot of money for the C-section, right? So they had a cost analysis tree here. You've got a woman with breech presentation, and she either has a version or no version, and then the version is either successful or unsuccessful, and the version is either with or without analgesia. And the conclusion was that the overall success rate they looked at 6 studies. Overall success rate with analgesia was 60%. Without analgesia, it was 38%. And the mean cost for delivery, if you did a cost analysis using those numbers, was cheaper if patients had neuraxial analgesia, as long as the increase in success rate was greater than 11% above the baseline. So if the baseline is 38% and you can add analgesia and get a success rate of 49%, then it's cheaper to do neuraxial analgesia, all right, on all patients, even though some of them will end up with a C-section, than it is not to do neuraxial analgesia. So the argument that it's more expensive should not hold out as long as it improves your success rate. All right, second topic we're going to talk about this morning is the PUBs, percutaneous umbilical cord sampling, which in my institution we call fetal blood sampling, all right? And, you know, I've never done this. So you're asking me to talk about something that we don't do at my institution. So here's the question. How many people in their institutions as an anesthesia provider are actually involved in this procedure? Okay, so actually, it's a few people. Maybe they can come up here and give the lecture. All right. The good thing is that there is a practice guideline, I guess I would call it, that was published by the Society for Maternal Fetal Medicine just last year in 2013. And they reviewed all the papers out there on fetal blood sampling, and here is what they showed. It's a less common procedure than it was in the past, all right, so maybe that's why we don't do it very often. The most common indication for the fetal blood sampling is to treat severe fetal anemia, all right? Another indication is to diagnose and evaluate neonatal autoimmune thrombocytopenia, and a less common indication is to evaluate non-immune fetal hydrops. All right, so those are the most common reasons that the procedure is being done today. This table is a little bit hard to read, but it lists all the studies that have been done on fetal blood sampling and published in the literature. And we can look at these 2 columns right here. The first column in purple right there is when is maternal sedation provided, may or may not be by an anesthesia provider, but whether or not the studies indicated that maternal sedation was provided. And the second column is local anesthesia used. And about half the studies, they didn't even say whether or not they used sedation or anesthesia. You can see that most institutions that publish their data do not use sedation, and about half of them suggested that they use local anesthesia. All right? The risks for fetal blood sampling, the most common risk is fetal bleeding. It's usually self-limited, but it occurs in 20 to 30% of procedures. And then the second most common risk is abnormal fetal heart rate, all right? And this is why we're involved in my institution. So we're not actually there when they do the procedure, but we see all these patients ahead of time, all right, in case they run into problems during the procedure. So we do a preoperative evaluation. We know that the patients are having the procedure done. In case there's a reason to do a crash C-section or something, we've already evaluated the patient's airway and know who they are. But we, in my institution, are not directly involved in the actual procedure itself. So the final table in the document is a table summarizing technical aspects of fetal blood sampling. And as you can see, what they stated for maternal sedation is that it's not done in most institutions, and that many institutions will use local anesthesia, which is obviously usually done by the obstetric provider. All right, and the third topic we're going to talk about today is trial of labor after cesarean. Dr. Hawkins touched on this a little bit today, and I want to go into slightly more detail in terms of what we do as anesthesia providers. So I'm going to ask you to participate again and raise your hands. Who works in an institution where TOLAC is provided? All right, and then put your hands down just so we can really count here. Who works at an institution where TOLAC is not offered? So not as many as the data that are out there, which suggests that about 1/3 of institutions or more in our country, I think Dr. Hawkins' data was like 40%, right, or 45%, do not offer TOLAC, all right? So we work in enlightened institutions. That's good to know. All right, so here's a few definitions, just in case you're not up on it. TOLAC is trial of labor after cesarean. I think that is the preferred term these days. VBAC means vaginal birth after cesarean, so if the TOLAC is successful, it results in a VBAC. ERCD is elective repeat cesarean delivery, which many of our patients are undergoing. And then an obvious outcome also is failed or unsuccessful TOLAC, which means that a woman tried to deliver vaginally but was unsuccessful and ultimately ended up with a C-section. So why are we talking about this? Well, you know, our C-section rate is going up. I'm going to show you a graph of that in a second. And about 1/3 of the C-sections that we now do are elective repeat cesarean deliveries. So if our overall health goal in our country is to reduce the number of cesarean deliveries that we do, one way of doing this is to decrease the number of elective repeat cesarean deliveries that we do and increase the TOLAC rate. So here is a graph, and let me orient you for a second. The green line right here, which is a little bit difficult to see, is the primary C-section rate, and the red line is the overall C-section rate, all right? The blue line right here is the TOLAC rate, and this line up here is the elective repeat cesarean delivery rate. So the first thing you can see, obviously, is that there's a couple of waves in this line over the past couple of decades. Starts got to back up here for a second. Starts in, what does it say there, 1988? 88? Yeah, okay, and this is 2008. So that's 20 years worth of data, all right? So we've got a couple of waves and curves here. So what I want to point out is a couple of things that have happened in the past couple of decades. This is the problem when the computer's not here, is that I can't read the fine print. 1995, okay. In 1995, you can see that the elective repeat cesarean delivery rate was at its low, okay? It kind of hit a nadir here. And the TOLAC rate was pretty much near the top of its graph or curve right there. And that's because ACOG at that point said in their practice guideline, in the absence of contraindications, a woman with one previous cesarean delivery and a low transverse incision is a candidate for VBAC and should be counseled and encouraged to undergo trial of labor. So that was the attitude in 1995. In fact, the attitude was so prevalent that there were insurance companies in this country who would not pay for an elective repeat cesarean delivery unless there was a trial of labor. Now that's quite radical, but there was a big push to have trial of labor. Then several years later, a landmark study was published in the New England Journal. This was a retrospective study of data from Nova Scotia, all right? And they compared maternal complications in women who underwent a trial of labor compared to those who had an elective cesarean delivery. And you don't have to look at the details other than to know that the risk of maternal complications was higher in the trial of labor group compared to the elective repeat cesarean delivery, all right? And this was kind of the start of the elective repeat cesarean delivery rate starting to go up, okay? Then, what year is this? 99. 99, thank you. Okay, 99, ACOG published their infamous guideline, all right, which said that the physicians need to be immediately available. All right, we'll go over that in a little bit more detail in a minute. And now you can see that the elective repeat cesarean delivery rate is really going up at a steep level, and the TOLAC rate is taking a huge dive. All right? And then the nail in the coffin was a study that was published in 2001, again in the New England Journal. This was also a retrospective database study from the state of Washington, in which they looked at uterine ruptures as an outcome. And of course, what they showed is that women who undergo trial of labor have a higher uterine rupture rate than women who undergo elective cesarean delivery. And they showed that the relative risk, all right, was 3.3% for someone in spontaneously labor, and it was as high as 16% higher, 16 times higher, sorry, relative risk, when someone has an induction of labor with prostaglandins. This was accompanied by an editorial by Dr. Michael Green, who is an obstetrician at the Brigham in Boston, and what he said was that after a thorough discussion of the risks and benefits of attempting a vaginal delivery after cesarean section, a patient might ask, but doctor, what is the safest thing for my baby? And given the findings of this study, my unequivocal answer is elective repeat cesarean delivery. All right, so that was the death knoll for TOLACs, basically, okay? And you can see, if you look to the right of the graph, that again, the elective delivery rate continued to rise, and the TOLAC rate continued to fall. So it is now currently less than 10% in this country, the TOLAC rate. Okay, so now the end of the graph is 2008. So in 2008, Dr. Hawkins mentioned this earlier, the NIH and NIHCD put together a consensus conference and called together a panel of so-called experts to look at the data about TOLACs and elective repeats and to make some suggestions. And somebody already mentioned earlier that consensus conferences are interesting because it means you have to have a consensus. I was the anesthesia representative on this panel. It was led by a maternal fetal medicine specialist, but there were also epidemiologists, midwives, nurses, a layperson, a urogynecologist. There was a broad group of representation on this consensus panel. As part of the NIH consensus panels, they have someone do a systematic review of all the literature. So I'm going to go over a little bit of the data on the systematic review that was prepared for this consensus panel. So if we start out, a woman who's had a previous cesarean's got two options, right? Before she goes into labor. She can plan to have a trial of labor after cesarean, or she can plan to have an elective repeat cesarean delivery. If she plans to have a trial of labor after cesarean, what is her overall success rate? And again, sorry for the busyness of the slide, just look at the bottom. Okay, the number is 75%. A woman who elects to undergo a trial of labor is 75 out of 100 times she will be successful. 25 of 100, she's going to end up with a C-section after the trial of labor fails. All right, so that's pretty high, 75%. The meta-analysis was asked to look at a number of outcomes, so both maternal outcomes and perinatal outcomes. The maternal outcomes were death, uterine rupture, hysterectomy. You can read them there. A long-term outcome that's obviously important is multiple cesarean deliveries, because we all know that multiple cesarean deliveries are associated with a markedly increased risk of maternal hemorrhage and death. But we're just going to look at the short-term ones right now because that's where the data are, all right? The most important one, I think you'll all agree with me, is maternal death, and these are data that Dr. Hawkins showed you this morning, all right? The risk of maternal death is over 3 times higher, all right, for a woman undergoing elective repeat cesarean delivery compared to a trial of labor. Now, the absolute numbers are very low, all right? This is per 100,000 deliveries, but it's very much higher in women who go an elective repeat cesarean delivery, okay? And again, I don't think, as Dr. Hawkins said, that's widely appreciated. So what is the risk? The risk that everybody's worried about is the risk of uterine rupture, right? What is the risk of uterine rupture with the TOLAC? If you put all the studies together, again, it's kind of a busy slide, but the number that you want to look at is about 0.5%. All right, so 1 out of 200 women who undergo a trial of labor will have a uterine rupture. That's actually a pretty high number, okay? And that's what everybody's worried about. So it would be lovely if we could predict who was going to have a uterine rupture, because then we could just tell those women to have an elective repeat cesarean delivery, and we'd not have to deal with the uterine ruptures. This is a meta-analysis that was done, not a meta-analysis, analysis that was done by Dr. Groban from my institution, looking at the Maternal Fetal Medicines Network database of cesarean deliveries. And what they found is that there are only two variables that predict uterine rupture. One is a previous vaginal delivery, all right, and that was a negative predictor. In other words, a woman with a previous vaginal delivery was less likely to have a uterine rupture, all right, and a woman who was undergoing induction of labor was more likely to have a uterine rupture. It wasn't, however, though, very predictive. So I think you've seen a couple of these the past couple of days. This is what's called a receiver operating characteristics curve, all right? And on the y-axis is sensitivity, and on the x-axis is 1 minus specificity. And a good predictive model, all right, will have a curve that looks something like this, and the area under the curve will be close to 1. Because if you have 100% sensitivity and 100% specificity, that curve is 1 by 1, and then you get 1 by 1 is equal to 1, right? Okay. If the model is not predictive at all, okay, the area, in other words, 50-50, you could just toss a coin and it would be just as good, then the area under the curve will be 0.5. All right, so for this predictive model, the area under the curve was 0.62 or 0.63, not really good, not a whole lot better than tossing a coin. So the long and the short is we don't have a very good way of predicting who's going to rupture, unfortunately. All right? This is just a summary slide looking at all of the maternal outcomes, all right? I told you about the one for death. It is the only maternal outcome where the grade of evidence was graded as high. And again, women are more likely to die with an elective repeat. The opposite is true for uterine rupture. Women are more likely to have a uterine rupture if they have a trial of labor. For hysterectomy, there was no difference between the groups, and for these other outcomes, hemorrhage, infection, etc., there was not enough evidence to really be able to say whether one group had a higher risk than the other group. All right, so that's a summary of the maternal outcomes. They also looked at neonatal outcomes, all right, again, short-term outcomes and long-term outcomes. The most important neonatal outcome, I think we would all agree, would be perinatal death. And here the outcome was the other way around, okay? So babies were more likely to die if their mothers underwent a TOLAC compared to an elective repeat cesarean delivery. Now again, the absolute numbers are relatively low, all right? These numbers are no different than the risk of a baby dying for any other reason during labor, all right? But the babies are at higher risk if they undergo a TOLAC or their mothers undergo TOLAC, all right? So this puts the mother and the obstetrician, and I guess us, in kind of a uncomfortable situation, all right? So if a woman makes a decision for elective repeat cesarean delivery, she's putting herself at higher risk, although the baby will be at lower risk, okay? And if she elects to have a TOLAC, there is less risk to her but more risk to the baby of death, okay? But I think we would all agree, and this is what the consensus panel thought, that's not a decision that we as providers should be making by ourselves, all right? And if we say to a woman, you cannot have a TOLAC because our hospital doesn't do TOLACs, then we are making an ethical decision that should be a personal decision of the woman and her family. We as providers are making that, or the institution's making it, or our system is making it, and the woman and her family are not making it. So that was part of the reasoning behind some of the recommendations that were made by the consensus panel that I'll go through in a second. Again, this is a summary slide of neonatal outcomes. I just went over the death with you, okay? The grade of evidence was determined to be moderate. It's not high, all right? But the evidence would suggest that the risk of neonatal death is higher with TOLAC. For all these other neonatal outcomes, including respiratory depression, NICU admission, et cetera, there was not enough evidence to say that it went one way or the other, depending upon the mode of delivery. All right, so here's just a summary slide. Maternal death is higher with elective repeat. Uterine rupture is obviously higher with TOLAC, and perinatal deaths are higher with TOLAC. So if a woman decides to undergo a trial of labor, all right, we said 75% of the time it ends up with a vaginal birth. That's pretty good. But 25% of the time it fails. So it would be nice if we could predict who is going to have a successful TOLAC. So again, Dr. Groveman, who's into predictive models, I think you've gotten that feeling right. Oh, let me tell you this first. One of the reasons that we'd really like to know whether or not the trial of labor is going to succeed ahead of time is because if you compare outcomes of women who have a trial of labor and then have a VBAC, in other words, the trial of labor is successful, compared to women who have a trial of labor and end up with a C-section, 75-25, remember? Then the women who have the unsuccessful trial of labor have worse outcomes. That kind of makes sense, right? And if you put all of this together, then women who have an unsuccessful trial of labor have the worst outcomes, women and their babies, compared to an elective repeat, which is kind of in the middle, and the best outcomes are women who have a successful TOLAC. All right, so we would like to be able to predict who's going to have a successful TOLAC ahead of time, right? This is a model prepared by Dr. Groban. There are a number of factors that predict successful or unsuccessful TOLAC, and it'll be a little bit hard for you to read, but they include maternal age, race, ethnicity, previous vaginal delivery, indication for the first C-section. This is a nomogram that you can actually go online and you can plug in all the numbers for your particular patient and you can come up with a number based upon the model, her chances of having a successful vaginal delivery. So all of the TOLAC patients in our institution have this calculation done. The OB residents do it. So it will say in the admitting obstetric note that the calculation is that this patient has a 60% chance of succeeding. And I always ask our residents when they give me a report, what's the number, okay? Because I think it helps us as anesthesia providers to plan ahead of time. If we know that she's only got a 25% chance of succeeding, we're likely going to have to do a C-section on this patient. Might change a little bit how we manage the patient compared to she has a 90% chance of succeeding. All right, so this nomogram is out there available to anybody on the web. And if you look at the ROC curve for this particular model, the area under the curve is better. It's still not super, but it is better than the one that we previously discussed, 0.78, right, closer to 1. All right, so Dr. Hawkins spent a lot of time, which is good because I'm running out of time, talking about the recommendations or some of the recommendations of the consensus panel. You know, one of the thought processes behind the consensus panel, too, is that one of the things that they recommended is that both ACOG and the ASA reconsider their recommendation for immediate availability. And the reason for that is, number one, this ethical consideration of we're telling mothers how to behave and what risks they should take. But the second thing is that, you know, the risk of something bad happening to a woman who's TOLACing is not any different than the risk of cord prolapse, all right? The rate occurs at the same rate. But we don't demand immediate availability of either the obstetric provider or the anesthesia provider just in case there's a cord prolapse and there's a bad outcome. There's a lot of other bad things that can happen on the labor and delivery unit, and we do not demand by guidelines that those providers be in-house. So why are we making a special consideration for women who are undergoing trial of labor? All right, that was one question. Anyway, as you heard earlier, both ACOG and the ASA revised their guidelines in 2010 after the consensus document, all right? And I won't go through those because Dr. Hawkins went through them. I put this slide in there yesterday because this was a question, right, at the panel discussion yesterday afternoon. So somebody asked what immediate availability is. So the ASA actually last year came up with the definition of immediate availability. This is from the Committee on Economics. And in case you can't read it, I'll read it to you because I think it's a question that everybody has. A medically directing anesthesiologist is immediately available if she is in physical proximity that allows the anesthesiologist to return to reestablish direct contact with the patient to meet medical needs and address any urgent or emergent clinical problems. These responsibilities may be met through coordination among anesthesiologists of the same group or department. Differences in the design and size of various facilities and demands of the particular surgical procedures make it impossible to define a specific time or distance for physical proximity. So, you know, that's pretty broad. It can let you get away with anything, all right? But that's what's out there now in terms of how the ASA defines immediate availability. All right, I think within reason, you can decide what immediate availability is in your institution, is what that says. Okay, I want to go over 2 more things before we stop here. So we talked about being worried about uterine rupture. So the most sensitive indicator of uterine rupture is fetal bradycardia, all right? Occurs 70% of the time. Increase in or change in uterine contractions, loss of fetal station, vaginal bleeding, hypotension. Okay, those are all less sensitive signs, but the one that we actually as anesthesia providers need to be aware of is that another sign of uterine rupture is new onset pain or pain between contractions or a change in the pain pattern, all right? Shoulder pain has been described. We've seen a couple of these at our institution. Presumably when the rupture occurs, there's blood that gets up under the diaphragm and the patients get referred shoulder pain. So why is this important to us? Because we as anesthesia providers have diagnosed a couple of uterine ruptures because we get called back into the room because the patient's having breakthrough pain. Before the fetal bradycardia occurs, the patient starts complaining of weird pain. So we need to know that if we get called back into the room for breakthrough pain, and a patient who's having a TOLAC, we have to keep uterine rupture at the top of our brains, right? This is a possible etiology of the breakthrough pain. I mean, there's a lot of other reasons for breakthrough pain that are more common than uterine rupture, but we can't forget about the fact that this woman might be having a uterine rupture, and the earlier we diagnose it, the better the outcome. All right, so to conclude, TOLAC success rate 75%. Maternal mortality is higher for an elective repeat, but perinatal mortality is the opposite. The worst outcomes are for unsuccessful TOLAC. Sorry, I misspelled subtle. Subtle guideline changes in 2010. All right, and then we need to remember that in women who are having TOLAC, who have epidural analgesia, breakthrough pain is a sign of uterine rupture. Okay, I won't repeat all that because you know it already. Thank you very much for your attention.